Let's talk about the management of diabetes now. So patient will come with a chief complaint of polyuria, which is frequent urination, polydipsia, which is excessive thirst, and polyphagia, which is excessive hunger, right? And in some cases, patient might complain of delayed wound healing also. On examination, we will do GPE plus systemic examination, but this is not something from which we can rule out diabetes, right? Then most importantly, we'll do investigation of the patient, that is fasting blood sugar and HbA1c, and in some cases feasting blood sugar also. For fasting blood sugar, the normal range is 70 to 110 milligram per deciliter. Pre-diabetic is 110 to 125 milligram per deciliter, while for diabetic patient, the fasting blood sugar will be above 126 milligram per deciliter, right? And for the feasting blood sugar, the normal is below 140 milligram per deciliter. For pre-diabetic, it is 141 to 199, and for diabetic patient, it is above 200 milligram per deciliter, right? Now the most important one, HbA1c. The normal range is below 5.7%. For pre-diabetic, it is 5.7 to 6.4%, while for diabetic, it is above or equal to 6.5%, right? Now let's discuss the management of a diabetic patient, right? First of all, for a pre-diabetic patient, we will advise lifestyle modification. That is, we will tell the patient to say no to sedentary lifestyle, reduce the weight for 10%. Remember that reduction in 10% of the weight will cause delay in 10 years of diabetes, right? We will advise walk to the patient to reduce carb intake, and also to check RBS once a week, right? Then we will write oral hypoglycemic, which is metformin, which comes under the name of tab glucophage, 500 milligram BD for 3 months, right? Now let's talk about the management of diabetic patient. Like if the fasting blood sugar of a patient is above 126 milligram per deciliter, or most importantly, if the HbA1c of the patient is above 6.5%, then we will figure out that the patient is diabetic, right? So first of all, we will advise lifestyle modification. That is same for the pre-diabetic one. And secondly, we will write oral hypoglycemic. Now, if the patient is overweight, then the drug of choice is metformin, that is tab glucophage 500 milligram BD. And we will continue this dose for 2 weeks and monitor RBS 2 times per week, right? Then our target will be 130 milligram per deciliter. If we achieve this target, then we will continue with the same dose. But if we do not achieve the target, then we will increase the dose. Like we will increase tab glucophage 500 milligram to TDS, that is 3 times a day, right? And then we will continue this dose for 2 weeks, and if still the target is not achieved, then we will give tab glucophage 850 milligram TDS, which is about 2500 milligram, I guess. Remember, the maximum dose for the metformin is 3 grams, right? Now, in case 2, if the patient is underweight, then we will write tab Getrel 1 milligram BD, which is basically sulfonylurea, right? And we will check after 2 weeks. If the target is achieved, then we will continue with this. And if the target is not achieved, then we will write tab Getrel 2 milligram BD. The maximum dose for Getrel is 3 milligram, right? Sorry, 8 milligram.